Hello, my friends. It's Dr. Sharon with Clinic Reviews. Welcome to the Clinic Review family. This is my Happy Thanksgiving, Merry Christmas, Happy New Year, Happy 4th of July gift to you. I'm doing prioritization strategies. People ask me all the time to do these, and I will be honest, you get a lot of prioritization questions on the Nclex, so I'm going to be doing this for you today. Today I'm going to be talking about two specific types of prioritization, and then I just want you to know there's another one that we talk about in our Clinic Review. And I would strongly recommend you take a Clinic Review with us if you're getting ready to take the Nclex. Today I'm going to talk about two different prioritization strategies, one of which I already talked about in another video, and I'm going to just refresh your memory on it here, and we're going to practice it and show how it's different from the other prioritization strategy. So the one that I've already talked about is when you have one patient in the question, and all you know about them is their diagnosis. That's it. You don't know anything else. They just tell you the name of the patient and the diagnosis. The diagnosis could be COPD, heart failure, schizophrenia, ADHD. It doesn't matter. It could be anything. All you know is their diagnosis. And then they say, what findings would you report to the next shift? What findings are you most concerned about? What findings would you call the doctor about? Whatever it is, you always report or call about or are most concerned about the unexpected findings. Okay, and we'll focus on that as we go through questions. The other prioritization strategy is when you also have one patient and you have a diagnosis in the question, but you have more. It's not just a patient, the diagnosis. Now you know all kinds of things about them. You know about their symptoms. So the first one is where you have just the patient and the diagnosis. The second one is you either have the patient, the diagnosis, and the symptoms. And then they say which order would you implement first, or it may say which problem will you address first. And you have to look at all those symptoms in the question. So you have to take a minute to analyze the question. This isn't the kind of question you just automatically know the right answer. You have to take the time to look at all the symptoms, identify which one is the physiological or the objective finding, and you have to address that first. So your top priority is always physiological, which is objective, like measurable, right? You have a number to go along with it, or you have a very objective word that you know that means it's an objective problem. You address that first. If you don't have any objective problems, you address safety issues. If you don't have any safety issues, you address comfort issues. Comfort issues are subjective findings. They're the things the patient reports. I'm hungry, I'm in pain, I'm nauseated, whatever it is, right? Those are the subjective findings. Those are what you address third. And then if you don't have any of those, you can address the psych issue. Maybe they're hallucinating, maybe they're depressed, whatever it is, but you address the objective findings first, physiological, then the safety, then the comfort or subjective, and then the psych issues. Okay, so let's get going, starting to talk about some actual questions. All right, the nurse is evaluating and assessing a patient with a diagnosis of chronic emphysema. The patient is receiving oxygen at a flow rate of 5 mL by nasal cannula, which finding concerns the nurse immediately. Find by basilar crackles, a respiratory rate of 8 breaths per minute, the patient sitting up and leaning over the nightstand, or a large barrel chest. All right, so we look at the question. I say, well, I know I have a patient. I have one patient. And I know their diagnosis, but I don't know anything else. I don't know any symptoms or anything like that. All I know is they have chronic emphysema. And you might say, well, you know they're wearing oxygen. Okay, but that's not a symptom. That just tells me they're wearing oxygen. It doesn't really tell me anything. Okay, so all right. So emphysema. So now I have to say, well, out of all these symptoms, which one is unexpected for a patient with emphysema? In order to do that, so that I don't let my mind get distracted, I turn this into a series of true-false questions. So here's what I do. I say a patient with emphysema would be expected to have fine basilar crackles. Yeah? I mean, maybe they don't all have that, but it's certainly not unexpected, right? Chronic emphysema, they got all kinds of weird lung sounds, including probably wheezes and diminished lung sounds. But it's nothing major, so yeah, I'm okay with that. They'd expect to have fine basilar crackles, fine. A patient with emphysema, I would expect to have a respiratory rate of 8 breaths per minute. No. In fact, I'd probably be more likely to think they'd have a respiratory rate of about 20, to be honest, maybe even 24. Chronic emphysema, so I definitely would not expect 8 breaths per minute. That's under normal anyway, so 12 is the low end of normal, so 8's already slow, but I certainly wouldn't expect someone with emphysema to have a slow respiratory rate. So no, I don't expect that. That's unexpected. A patient with chronic emphysema, I would expect them to be sitting up and leaning over the nightstand. Okay, so I want you to picture this. They're sitting up and they're leaning over the nightstand like this. Now, what is this position called? This position is called tripod, whether they're standing up and leaning over or whether they're sitting up and leaning over. It's called tripod position. And this is the position we teach them to use when they feel short of breath. That's what we teach them. So they're doing exactly what we taught them to do. So we should be going, well, sure. I mean, I just taught them to do that. So why wouldn't they be doing it? Helps reduce any dyspnea. They're more comfortable when they're sitting like that. So yeah, I would expect that because I probably just taught them to do that. So yeah, I expect them to be sitting up and leaning over the nightstand. I would expect a patient with chronic emphysema to have a large barrel chest. Well, yeah. I mean, I guess you could say, why does it have to say large? Because it probably is. It's chronic. It's not like they were just diagnosed as far as I could tell. Why not have they could very easily have a large barrel chest. It would still be right if it didn't say large, but I'm not going to overthink it and say I don't like the word large. It's okay. I'm okay with that word. So the only one that's unexpected is 2. Respiratory rate of 8 breaths per minute. I definitely would not expect that for a patient with emphysema. So I'm going to pick that as the answer that I'm most concerned about. Client who's been infected with the Ebola virus has an emesis of 750 mils of bloody fluid and complains of headache, nausea, and severe lightheadedness. Which action included in the treatment protocol should the nurse take first? Give acetaminophen, administer ondansetron, infuse normal saline, or increase the oxygen flow rate to 6 liters per minute. All right, so here I have a patient with a diagnosis and symptoms. One patient with a diagnosis and symptoms. And then it says, what am I going to do first? So now I'm saying to myself, well, which is the physiological finding? Because I have to address the objective physiological finding first, and then I can address everything else. So let's see if there's any objective physiological issues. Okay, Ebola virus certainly is an objective finding. Emesis of 750 mils of bloody fluid. Well, that's measurable, right? I just measured 750 mils. So that's certainly objective, physiological. So that's at the top of my list. Complains of headache. Well, that's subjective, right? That's just a subjective complaint, so that's comfort. Nausea, that's a complaint, that's subjective. Severe lightheadedness, that's what they're complaining of, so that's all subjective. Which action included in the treatment protocol? So I have to address the 750 mils of bloody fluid first. That's what I have to address. So they just lost 750 mils. So let's see if there's an order that addresses the fact that they just lost 750 mils. Give acetaminophen. Well, that's for the headache. So no. Administer ondansetron. Well, that's for the nausea. So no. Infuse normal saline at 500 mils an hour. Well, that's addressing the fact that they just lost 750 mils. Increase oxygen flow rate. I don't even have any oxygenation symptoms here. So I don't want to get distracted by the oxygen because we always go, we got to do oxygen first. Well, not if there's no oxygenation issues. And you might say, well, there probably are oxygenation issues. Well, you're right, there probably are, but you can't use the word probably when you're testing, okay? You only go with what you know, not what is probably true. Okay, so the only thing that addresses the objective problem is the saline. And you might say, well, Sharon, the ondansetron addresses the emesis. No, it doesn't. The ondansetron addresses the nausea. And you might say, well, why not give the ondansetron first so that they don't throw up again? Because this is not how you test. I mean, you can say in real life, I'd give the ondansetron first. Well, first of all, you wouldn't give the ondansetron first. Not after they just lost almost 1,000 mils of fluid. You would not give the ondansetron first. You'd be running around to get that fluid replaced is what you'd be doing. So first of all, you wouldn't give it first. Now, you may have a second nurse at the bedside who's giving the ondansetron while you're doing the fluid. That's fine, but I know you wouldn't give the ondansetron first, so don't tell me that's what you would do. The nurse is caring for a newly admitted client with increasing dyspnea, hypoxia, and dehydration who has possible avian influenza. Which of these prescribed actions will the nurse implement first? All right, so here we have a patient with a possible diagnosis, avian influenza, and a bunch of symptoms, and they want to know what order we'd implement first. Start oxygen, infuse D5 water at 100 mils an hour, administer the first dose of oral oseltamivir, obtain blood and sputum specimens for testing. All right. So we have to figure out which is the physiological objective problem, and then we have to address that first. Dyspnea. Do you know dyspnea is subjective? That's the patient reporting their dyspneic. So that's subjective, that's comfort. Hypoxia. Well, that's actually objective. You can't say somebody's hypoxic if you don't have an O2 sat to back that up. So it's for me to say they have a low O2 sat is not assuming anything. That's what the word hypoxia means. So hypoxia is objective. Dehydration. Well, dehydration is also objective. I can't say they're dehydrated if I don't have evidence for it. So that's by definition, that's objective. Possible avian influenza. Okay, fine. Which of these prescribed actions will the nurse implement first? All right, so start oxygen. What does that address? Well, that addresses the hypoxia. All right, I like it. Infuse D5 water. Well, it's the wrong solution, but if it was the right solution, it would be addressing the dehydration. Administer the first dose of oral oseltamivir or obtain blood and sputum specimens. Now, so we're going to cross off the blood and sputum specimens because that's not addressing any of the issues. And you might say, well, why wouldn't we administer the first dose of oral oseltamivir? Because, well, first of all, it's possible avian influenza. And second of all, we have a clear, objective, high-priority problem that we have to address first, and that's the hypoxia. So we have to do that before we do anything else because that is the clear, objective physiological problem. So if I use my ABCs to prioritize between physiological problems, if I have two physiological problems, I go, well, which one do I do first? Well, I use my ABCs, so I'm going to do oxygen. However, I would never use D5 water to rehydrate. I would only ever use normal saline to rehydrate. So I wouldn't pick two anyway. Now, just to give you a heads up here, sometimes you'll have two physiological problems and neither one of them are ABC. And then you go, well, which one do I prioritize then? So let's say you had diarrhea and malnutrition. Those were your two problems. Both physiological, objective, diarrhea, malnutrition. But neither one of them are ABC. So then I say, well, which one's acute over chronic? So I go with acute over chronic. And diarrhea is acute, malnutrition is chronic. By definition, you don't become malnourished overnight. So I'm going to have to go and treat the diarrhea first. An 88-year-old client who has not yet had the influenza vaccine is admitted after reporting symptoms of generalized muscle aching, cough, and runny nose starting about 24 hours previously. Which of these prescribed meds is most important for the nurse to administer at this time? So I have one patient with a possible diagnosis. They don't say it, and I don't love that they don't say it, except they make it pretty clear that this person probably has the flu. They say they didn't have the vaccine, and all their symptoms are the symptoms of the flu. So it's really pretty clear that they probably have the flu. So what are the orders? Oseltamivir, guaifenesin, acetaminophen, and influenza vaccine. Whenever you see a drug that has VIR at the end, that's an antiviral. And oseltamivir is Tamiflu, and so that's for the flu. So let's see. So they probably have the flu, and then the symptoms are what? Well, do you see it says admitted after reporting symptoms? That means every single one of the following things are subjective. Muscle aching, cough, and runny nose, all subjective. And you could say, well, cough is objective. Well, it's not when they say they reported it. If they say you observed them coughing, that's objective. If it says they reported a cough, that's subjective. So all of these are subjective findings. So oseltamivir is for the flu, guaifenesin is for the cough, maybe a little for the runny nose. Acetaminophen is for the general muscle aching, and the influenza vaccine. Well, I'm going to cross off influenza vaccine because there's no point in giving it right now. We can give it later if we want, but there's no point in giving it now. And 2 and 3 are for the subjective findings. The oseltamivir is for the flu, and because they make it very, very clear that they have the flu here, even though they don't say they have the flu, they make it really clear they probably do, then I'm going to go ahead and give that because having the flu is an objective problem. And you have to give Tamiflu or oseltamivir. You have to give it early or it doesn't do any good. So I'm going to go ahead and give that first. Because all the other symptoms are subjective, I can go ahead and give the oseltamivir first. Now, I wanted to show you the difference between this question and the previous question, because the previous question also had number 3, administer the first dose of oseltamivir. Why didn't we pick it then? Because we have a clear physiological, objective, measurable problem. And when we have a clear physiological, high concern problem like hypoxia, we have to address that first. We cannot say, oh, we're going to let him be hypoxic while we give him the oseltamivir. No, 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 no. Don't say that, okay? But I wanted to show you that the right answer is the right answer because of the other answers. Mark has said this. If you watch the interview with Mark that's on our homepage, he says, don't ever memorize answers from question banks because the right answer is only the right answer because of the other answers. And this demonstrates that. Both people have the flu, but here, one time we prioritize oseltamivir and the other time we don't. So do not memorize that oseltamivir or Tamiflu is always the priority for a patient with the flu, because it's not. It depends on the other symptoms and the other answers. During the initial post-op assessment of a client who has just been transferred to the post-anesthesia care unit after repair of an aortic aneurysm, the nurse obtains these data. Which finding has the most immediate implications for the client's care? All right, here we have one patient, and all we know is their diagnosis. We don't have any symptoms, no signs and symptoms of anything. So that means we got to pick the unexpected finding. Well, what's the diagnosis? The diagnosis is they just returned to the PACU after aneurysm repair. And pay attention to the just been transferred to the PACU. That's a key word, just returned. So let's read the answers. A line indicates blood pressure of 190 over 112. Cardiac monitor shows frequent PACs. There's no response to verbal stimulation. Urine output is 40 mils. All right, so I'm going to turn this into a series of true-false questions because I'm looking for the unexpected finding. So for a patient who is just transferred to the PACU after aortic aneurysm repair, I would expect their blood pressure to be 190 over 112. All right, don't ever say true to that. We never expect our patients' blood pressures to be 190 over 112, unless they tell me they were admitted in hypertensive crisis. Other than that, I don't ever expect their blood pressure to be high. So 1 is false. I don't expect that. For a patient just returned to the PACU after abdominal aneurysm repair, I would expect their monitor to show PACs. I don't know. I mean, maybe. I mean, as an experienced nurse, I say, well, actually, I wouldn't be that surprised because there's a lot of reasons why they could have PACs. But let's say I'm a novice, okay? If I'm a novice, I'm going to go, I don't know, maybe. I don't know. So don't be afraid to put a question mark next to it. Maybe, right? Question mark, okay? So we'll leave that on our list. 3, for a patient who just returned to the PACU after major surgery, I would expect there to be no response to verbal stimulation. Absolutely true. I mean, that's why they're in PACU, right? Because we're recovering from anesthesia. So of course they're not going to respond to verbal stimulation. So that's fine. For a patient who just returned to PACU after major surgery, I would expect the urine output to be 40 mils of amber urine. Yeah, that's fine. I mean, they just returned. They don't give me a time frame, so I can't say it's low because I don't know how long it's been. So, I mean, I have to say, sure, that's fine. So I'm going to cross off 3 and 4. So now I have to decide between 1 and 2. Well, which one is more unexpected? That they have PACs, which are not particularly dangerous dysrhythmias, or that they have a very high blood pressure? Which one am I more concerned about? Well, 1 is really the circulation issue, right? Because when you have really high pressures like that, that can affect circulation, and ABCs, that's circulation, right? PACs don't really affect circulation. You still have good cardiac output with PACs, so that doesn't affect anything. So I have to be most concerned about the blood pressure of 190 over 112. A patient with chemotherapy-related neutropenia is receiving filgrastim injections. Which finding by the nurse is most important to report to the healthcare provider? All right, so I have one patient, and all I know is their diagnosis, and that they're receiving a medication for that diagnosis. All right, the patient says my bones are aching. The patient's platelet count is 110,000. The patient's white count is 39,000. The patient reports that the medication stings when it's injected. All right, let's look at this. So what is the diagnosis? The diagnosis is neutropenia, and that's all we know. So we have to consider which finding is unexpected. All right, if you don't know this, neutropenia means low white count. You got to know that. Neutropenia means low white count. Now, there's two other words for it that you should know. Neutropenia also means low white count. Sorry, my handwriting's bad. And agranulocytosis also means low white count. Okay, so those two words mean a low white count. You don't want to miss the question because you don't know what the words mean. Mark always says, as long as I've known him, poor vocabulary is the #1 reason people fail Nclex. So you got to know the vocabulary. All right, so they're getting, it's chemotherapy-related low white count. All right, I get that. They're receiving filgrastim injections. So I'm going to assume, in this case, it's okay to assume that filgrastim is to increase white count. I mean, even though I've never heard of filgrastim, I say, well, it makes sense that that's to increase white count, okay? So I'm going to, and that's all I know. I don't have any symptoms. So which symptom, I don't have any symptoms in the question. So this isn't a physiological versus comfort versus psych issue, right? This is a what is expected versus unexpected. So for a patient who has a low white count, who's receiving a medication to increase their white count, which finding is expected or unexpected? Really, which one is unexpected? So for a patient who's neutropenic receiving a med to increase white count, I would expect them to tell me their bones are aching. That just, my gut tells me that seems okay to me. I mean, what is neutropenia? And if you're trying to increase white count, where are those cells going to be generated? Well, they're going to be generated in the bone marrow. So my gut says that I should expect that. So I'm okay with that. For a patient who's neutropenic, low white count, who's receiving filgrastim, I would expect their platelets to be 110,000. All right, if you don't know this, normal platelets are 150,000 to 400,000. Okay, so when we look at labs like in clinical, only is going to say 150 to 400. So sometimes that throws us off a little bit when we see these big numbers. So just know that normal is 150,000 to 400,000, and we don't usually worry about it until it's under 90,000. But even if you don't know that, you go, well, okay, the platelets are low. I mean, that's a problem. I don't know if I would expect that. So it's okay to say, I don't know if I would expect that. So put a question mark. We're going to leave it on our list. We're crossing through #1, but we're going to keep 2 on our list. For a patient with low white count who's receiving a med to increase white count, I would expect their white count to be 39,000. Whoa. Okay, normal white count is 5 to 10, and some people might say 4 to 11, and that's 1,000, by the way. So whether you say 5 to 10 or 4 to 11, it doesn't really matter because that ain't nowhere close to 39,000. I mean, think about this. Their white count was probably less than 4. They were neutropenic, right? So their white count was probably less than 4. Now we give them filgrastim, and all of a sudden their white count is 39,000. It's 3 times what it's supposed to be and probably 4 or 5 times what it was. Yikes, is that really expected? I don't think so. Okay, so we're going to definitely keep that on our list. So for a patient who's neutropenic, who's getting a drug to treat that, I would expect them to report that the medication stings when it's injected. Well, it is injected, and I don't know of any drug that doesn't sting when it's injected, so I'm going to say that's expected. So I'm going to cross that off. So now I have to say, well, which is more unexpected? That they have a slightly low platelets, or that they have a white count that's 4 times what it's supposed to be, and probably 5 or 6 times what it was to begin with? I think I'm a lot more concerned about that really, really, really high white count. I'm thinking that's what I'm really concerned about. So that's the one. That's the unexpected one. That's the one I'm going to go with. Well, thank you for coming along for another ride with me. And I wish you all the best on Nclex if you're taking it soon. And if you've got a little time to study, then make sure you go through some of our other videos. And I'll keep coming out with videos. Welcome to the Clinic Review family. Check out all of our reviews and where they're at clinicreviews.com. And I wish you all the best. See you later. Have a great day.